Hello, everyone. Good evening, good morning, depending wherever you are. I hope you're doing well. My name is Bhagyashri, and I would be the host for today's exciting event. Till our second panelist join us, let us begin with the introduction. Um, I would firstly like to thank you for taking this time out to attend the interactive learning power hour session hosted by Harbinger. For those of you who are joining for us for the first time, Power Hour is a series of interactive roundtable discussion amongst the industry stalwart, where they would be sharing their experiences and insight on a particular topic. So the topic for today's discussion would be healthcare insights from data. Before we begin, a few housekeeping tips. In case you are not able to hear the audio, ensure you have selected the right speaker for audio output. You may test the same to see if it is working fine from the audio setting options on the lower left corner of your screen. If necessary, please dial in using Zoom. With that, now it's time for the introduction. Our host for today's roundtable is Prashant Khambekar. Prashant has 20 plus years of rich experience in engineering, management, and business development of software products. He is the head of HealthTech line of business at Harbinger. His deep involvement in customers' products in the provider, payer, pharmacy, and clinical trial segments has worked wonders for the customers. Prashant enjoys writing and putting forth his thoughts on the evolving healthcare landscape. Blockchain, IoT, data engineering are Prashant's areas of interest and passion, where he is known to be leader in new initiatives. We welcome you, Prashant, and over to you.
Thank you, Bhagrashi. Thank you so much. Welcome, everyone. Hope to have an exciting time talking with the panelists. So let me go ahead and introduce Dr. Reddy. Dr. Reddy joins us today from Hyderabad. I have encapsulated only one aspect of his multiple facets over here. Dr. Reddy is a well-known cardiologist, and he has been in this field for many years, many decades actually, and very well respected, very popular cardiologist. In addition to all of this, he does a number of other activities. So he is he has founded Access Health International, which is essentially like an international body that tries to improve healthcare across multiple countries. So Access has, it's part in the US, it is in the Middle East, it is in India, of course, and it is in the Far East also. In addition to this activity, Dr. Reddy is also part of the National Health Mission, the NDHL, the Digital Health Mission specifically. So he is involved in making sure that the health benefits reach all parts of people in India, and also the new technology, the digital part, that is utilized properly. So it is not just only the physical aspect, but also the data aspect, the digital aspect, the whole technology aspect that is included in that. We'll wait a little bit for Dr. Trice to join us. Dr. Trice is also a practicing physician. He is into intensive care. He is into sleep management. He is into, he's a pulmonary specialist, and he is a founder of Pulmonary Apps. He is like an entrepreneur. There he joins us, I believe. He has been an entrepreneur, a businessman, and right from when he was a small child, he has been tinkering and taking apart things and putting them back and so on. So we have a wonderful blend of like a practical physician, working full time, but in addition, he is like also into technology and the business aspect. So we have like a wonderful panel here. Hello, Dr. Trice. How are you?
Hi, how are you today? Can you hear me okay?
Yes, we can hear you okay.
Great.
All
Just
right.
want to make sure.
So, yes, great to have you. So I'll jump ahead a bit, and I'll come shortly to Dr. Reddy and Dr. Trice, but just wanted to kind of lay out what we are talking about here. So there is something like 2 to 25 exabytes of data, just health data, and this health data, as you can imagine, is multifaceted. So there are vitals like, what is my temperature, what is my blood pressure, and so on. And then it's the history. Okay, what have I suffered from? What has been my pathology? What has been my, the immunizations? What am I allergic to, and so on. Then there are images. There is MRI, there is X-rays, all these kind of things. Then there are the specific treatments that I've gone through, or the medications that I've taken, which medications work well with me, which medications don't work well with me. And this is like an individual. And then if we take it to like multiple people, then we are talking about the populations of certain parts of the world or the entire world, as we are all interconnected, and especially the pandemic has brought this whole thing to our consciousness very clearly now. So I'll come to Dr. Reddy first, and I will ask him, if you can tell us a little bit more about your work and how data plays a role in it. Has data been useful to you in brief, and how important is it? Is it is it just of marginal importance, or is it of some significance to you? So, Dr. Reddy.
Yeah, thanks, Prashant, for the introduction. In terms of the data, what we use as a clinician, that is the first level of information as a clinician, how we use the data. Then as a healthcare manager, how we use the same data in terms of the healthcare management. As a public health professional, then I will use the data in a different perspective.
Yes.
More at a population level. As a clinician, I will use it at a personal health level. But at a public health professional, I will use it at a population level. Then if I'm a politician or a policy maker, then I will use the same data in a different perspective. And if I'm a payer, again, I can use the data in terms of how do I assess the risk of the people who are insured with me. Because that's the most important thing in terms of what is likely the outcomes and what are the likely use of the clinical services. So I'm extending the use of data from multiple roles that I'm actually playing. That's why I'm able to articulate as a clinician, as a healthcare manager, as a public health professional, as an evidence generator for the policymakers. So this is how I could summarize how the data can be used. In addition to that, from a clinical leadership perspective, more and more data that we are using in terms of how we organize our care services, in terms of the disease management programs, in terms of continuity of care. So it's not only just the data, how the technology platforms can be used to drive the care pathways so that there is a democratization of the cognitive excellence that rests with some of the clinicians.
Dr. Trice, good morning to you. You join us from Cincinnati, I believe. So same question to you. Has data been useful to you? How important is it in the spectrum of things that you do? And what is the importance of data?
Yes, hopefully you can see me okay. So I'm actually coming to you, yeah, from Louisville, Kentucky. And hi, Prashant, thanks for inviting me.
Hey.
Um, so, so, so data is an interesting thing for what I do. So there comes two parts to data. One is, as I believe Dr. Reddy said, when you're seeing a patient in the clinical setting, how does that really affect you? Sorry, I have two things going here, and I was trying to switch over
That's
to my
perfectly
computer.
fine. We understand that you're, that you're taking
I
time
just
off
didn't want to
from
give
your
the background
actual
echo there.
schedule as a physician, and so has
Sure.
Dr. Reddy.
I always have a backup just in case one of these doesn't work here. So, but data is interesting because we use it in the clinical space to really identify what a patient's going through. So, it's one-on-one. And like Dr. Reddy said, it changes when you start looking at large groups of patients. So going from what I call the bedside to the bench side, when you're really looking at larger groups of data, making sure that you have accurate data, one, actionable data is now, I think, one of the key problems. In my field, I do a lot with digital health, a lot with sleep medicine, looking at digital vital sign monitors. And one of the things you want to make sure is the data you're getting is the right data, first of all, and then that you're not getting a preponderance of data that's either background noise or unuseful. So whether, I'm looking at heart rate, do I want a heart rate every single second and look at thousands of data points, or do I want a trend? Do I want to make sure it's actually measuring that data? I think as we start to go from one person to looking at groups of people, whether it's designing policies or products or programs to allow more access to people, whether they're in rural or have difficulties with finances, or whether they have a rare disease state. The key is how can we get actionable information from the patient to the best provider who can deal with that in a manner that they can use. I always say that, there's data points, the objective numerical data, and then there's the subjective side of medicine, which is a little bit different than most other industries. And being able to take as much of the subjective data and put it into objective form, whether it's history taking or physical examinations, so that larger volumes of data can be assessed and adequately treated in a shorter period of time. So getting that efficiency to allow for those when you do have an outlier, whether it's somebody whose data is incorrect or they have something that needs to be explained more than kind of monetized or put into a numerical fashion. So for me, data is king.
All right. Okay. That sets the stage perfectly well for us. So I just want to give a general idea to the audience that the reason we are doing this is essentially for to get better insights, to be able to set policy, to decrease costs, to improve the care ultimately to the patients and to the population. Some of the techniques that are used by professionals is the basic analytics, just trying to determine what are the patterns and so on. Then there are artificial intelligence or machine learning techniques where more information can be extracted. And AI ML tends to work with numbers, but there is an increasing component of natural language that is important. As Dr. Trice said, it is the subjective part that is also important and also constitutes data. Just to indicate what some of the people have done, there is the spotting of sepsis from images. You look at it and look at an image of a wound or something, and you can tell whether there's likely to be sepsis or it is a fairly non-risky kind of wound. When it comes to structured data, trying to get information from what we already have, it is to predict the fall risk of senior people. Okay, who is likely to have be quite all right, and who is likely to have a lot of falls going forward, and therefore injuring themselves even further. In terms of data which is partly structured, you don't have a complete picture. You're kind of utilizing some heuristics and so on. It's about predicting no-shows. Now, no-shows are very important because if a patient does not show, then it affects the entire flow and the mechanism in which a clinic or a hospital operates, and it has further repercussions because of like money and so on. So predicting a no-show is an important thing, and that would be an example of something that is partly structured. In terms of like combination of image and natural language, some people are working on trying to capture what is indicated in an ECG and to summarize it in the form of words so that a quick summary is obtained, and at the same time it indicates what is the action that is most suitable for a particular patient. Going further, again, like if you come to a player like Google, then they are able to predict certain diseases by examining the images of the eye, and it has nothing to do with the eye, so they can tell whether it is either like say heart disease or some other disease that is prevalent. That is the level at which certain kinds of artificial intelligence is able to operate nowadays. One interesting thing with regards to the COVID pandemic was that because of Google having geographic data, it was able to determine the spread of COVID from search queries such as "I cannot smell." So if that was what different people were typing into their search engine and had nothing to do with like health or health system or health data as such, but Google was able to match and correlate and kind of indicate that, okay, there's likely to be the spread of COVID in one geography as compared to another geography. So this is a very varied kind of like field. And let me ask Dr. Reddy and Dr. Trice about their experiences. Data and its processing and the ability for it to like do predictive analysis or possibly prescriptive analysis. So are we talking about a real benefit, or is it still a hype cycle? Dr. Reddy.
Yeah, sorry, it was slight hang-up was there on the line. I mean, in terms of how information is used, in technical terms, you call it as a data, but from a user perspective, we use it as information. Because a lot of information is there in front of our eyes in terms of the lab reports, in terms of the vitals and the monitors. But what is missing is how this data is actually used. I think that is one aspect has to be crystallized. But the second aspect of the data use, I don't think there will be any second opinion as to the use of this data in the future as we go forward. Especially when we have the real world data of large number of patients, not just few patients that we are managing. As a clinician, when we use our judgment, the standard of care, we base our standard of care on some of the evidence-based trials and some of the strictly controlled variables. But in the real world, when we actually practice our medicine, a lot of other variables come into picture. So that's where I think in the future, the real world observatory data accumulating from multiple patients, multiple data points, we'll be able to narrow down the standard deviation from the mean as the data gets accumulated. So when you have those dynamic information on a real world practice level, you will be able to actually fine tune and individualize the treatment learnings from this data. So that's, I think, one important aspect of it. To plan your treatment as per the evidence which is getting generated live. The second element of the artificial intelligence, if you look at the clinicians' population, not everybody has the same level of cognitive skills. Somebody may require enormous data to come to the same conclusion, the diagnostic conclusion or the therapeutic plan. But when you have a technology enablement which assists the clinicians to arrive at the same conclusion as the best clinician. So why should the patient have that uncertainty of the best clinician versus the worst clinician in terms of the cognitive skills? That's where I said the democratization of the cognitive skills. I mean, suppose every clinician is able to get what the best clinician can arrive at a diagnosis or able to apply his learnings from the evidence-based research into the actual planning of the treatment. So that I think that's where the AI is going to come in terms of the clinical decision support based on the real world data and accurate analysis. The third role of AI is going to be in terms of reaching out to the inaccessible areas. I mean, unlike the developed world, the rest of the world has a lot of inaccessible areas where you may not get the expert radiologist or expert pathologist, you may not have enough ophthalmologists. So that's where the technology will be able to enable that even in the inaccessible areas, you may be able to get the expert opinion. For example, if you don't have anything, even the PCR testing in the beginning, and somebody is able to analyze just based on the X-rays and some of the basic CT scans, that you may be likely to have the COVID. So that's a tremendous use of the data. The fourth thing that I can foresee is in terms of now that the COVID is going on, in terms of how this health system resilience of the pandemic preparedness, just from the data of suppose there is a sudden spike in the use of paracetamol, a sudden spike in the use of antiviral drug, or there is a consumption of a particular diagnostic test, you will be able to pick up the early onset of a possible epidemic spike in a particular geography. The technology permits such a prediction of that. And we have witnessed the use of the data, especially say in countries like China, I mean, where they have total control on the technology, irrespective of the privacy and other things. So you have been still able to use that technology, power of technology for the good of the population. It may be used for the bad of the population as well, but at least we have a demonstration, clear-cut demonstration of the good of the population. So this is, I think we can go on listing out multiple things, including how you can regulate, say, infusions in the home ICU setting through the IoT with a trained nurse at the bedside. But you, as a critical care specialist, you can actually titrate the supports in a remote fashion, which was not possible without this, the new age technology. Yeah, so I stop here. I think my co-panelist, I think Kevin, can also elaborate on more usage of this data.
Yes, Dr. Trice, please. And if you can, of course, indicate your views on this, but also like the use of the AI techniques and similar, is that only for like some limited narrow areas within healthcare, or is the scope growing? So if you can talk about these.
Well, I concur completely with what Dr. Reddy said. I mean, right now, I think it's limited only by a lot of fear and then a lot of validation. So when I look at artificial intelligence being, I don't think it's hype any longer. I think, over the past 15 to 20 years, we've had a kind of a slow progression as people were slow to adopt, small things, wearable devices, protocolization of treatments and diagnostics. But as we've seen its effectiveness, being able to look back and study the results, now people are understanding the benefit of using data. And to me, artificial intelligence, it just uses the power of computing to look at even larger sets of data faster. And so I think of it in three ways. I think of its biggest impact will be in the monitoring spaces where it has been. That's being able to monitor, again, patients remotely, whether, it's things like Fitbits, Apple Watches, or Android watches, remote or Bluetooth or Wi-Fi powered, heart rate sensors and blood pressure sensors, digital scales, to get the very basics of information. But it's also been used in terms of electronic health records, being able to take large amounts of subjective data and put it into objective forms just to get the actual data in. So the monitoring portion, I think the two big parts that are really kind of coming along right now in the pipeline are changing from monitoring to diagnostics. So taking that data and actually coming up with an accurate assessment. So, when we're trying to get the right diagnosis, you mentioned earlier, looking at, for instance, subjective data, like I've lost my smell, my taste, how much of that volume correlates to the predictive capacity of this being a particular disease state, and with what level of accuracy, in other words, specificity and sensitivity. So I think that's crucial because we can look at what people say and actually predict the correct diagnosis or series of diagnoses. In doing that in a much faster way, also much more cost efficient, but also reaching larger groups of people because it doesn't require coming into a hospital center. So whether an emergency department or a doctor's office, for those who may have difficulty with transportation or cost or just ability, it really allows to get accurate, fast diagnosis cheaply. And then I think the third part of that is, going from monitoring to diagnostics to treatment. And so really being able to go down to, once we're getting a diagnosis, what is the right treatment? And we can do that not only just on looking backward at other population data, but really even getting to the point where we're predictive now. We're predictive based on your blood type, your genetics, where you live, the way things are changing in an area. So when I'm trying to look at, 5 million or 50 million examples of a particular diagnosis, for instance, COVID-19, and what are the response to treatment patterns in this particular geographic area or in this particular subsegment of patients, whether based on age, gender, race, underlying health conditions, other medications, their ability to actually absorb a medication. I think artificial intelligence has an incredible role in being able to do that. I think it has an ability to shift the cost structure of how we provide care from being mostly inpatient to really, right now it's all inpatient. There's very little outpatient care, very little preventative medicine, to being able to kind of even out those scales. So the hospitalizations, what we refer to those who fail appropriate outpatient therapy, but most likely had an accurate diagnosis in a timely fashion. And so it should also reduce the care. So I think it's definitely here to stay. As Dr. said, it's definitely not going away. I think we'll see more of a change from the consumer space, although consumers are hungry for getting more data as well, mostly into a more, certified medical space where we're able to really treat patients either, again, at home in pop-up centers, but in a much smaller footprint that makes it cheaper and easier. But I think the key is really going to be going from monitoring to diagnosis, and from diagnosis to treatment. I think the diagnosis to treatment is really when we'll see the largest economic impact on patients everywhere, particularly those who have difficulty getting in or have hesitancy to going in to see a physician.
That's great. But is the applicability still limited to some very narrow areas based on like where AI can be accurate? Is it only for like certain diseases or certain treatments? What is your experience in that?
Go ahead, Dr. Reddy.
Dr. Trice, you go ahead first, and then Dr. Reddy.
Okay, sure.
As you wish, as you guys wish.
I think right now it is limited to, where the money is. So, you're looking at cardiovascular disorders for the biggest part, they're the biggest bang for the buck for most hospital systems. With the global pandemic and COVID-19, clearly things have shifted. We've seen, emergency use authorizations for medications, for devices. So I do think it's going to be limited to the things that are very expensive and very deadly and affect large groups of people. So right now, I think the focus will be mostly on, clearly pneumonias, being able to differentiate because there's such a high risk of not just mortality, but cost and getting patients into intensive care units. We know that if we can predict that they have the disease, get the diagnosis correct at an earlier stage, we can use outpatient treatments that are much cheaper and also effective and reduce the chance of death cost. So I think that's where you're going to see a lot of it. It has been. I predict in the next 12 to 18 months, from cardiovascular disorders, from particularly heart failure, coronary artery disease or atherosclerosis, COPD, diabetes. These will be the big ones. Some of the more orphan diseases or rare diseases, of course, will take a little bit longer just because they're not as supported economically. But I think getting those core groups of people, when you look at the top 5 reasons for admission or readmission within 30 days, that's where most of the focus is being put. And vital signs, we call them vital signs for a reason, because they are vital. But then getting that second level of information, I think that's where we're going to see And I shouldn't say going to say, we are seeing, people are already putting our artificial intelligence to the test to say, how can I predict which one of my 75 heart failure patients that I follow on a monthly basis is going to be readmitted within the next 30 days? Some hospital systems are doing it on a called a regional scale. So maybe 2 or 3 hospitals in the area. I think there's still a little bit of hesitation about producing it large scale. But I predict within the next 12 to 18 months, with COVID changing the way we practice medicine, doing more telemedicine, doing remote, using more objective data, I suspect that we'll see this enormous switch in terms of getting people out of the emergency departments using artificial intelligence.
Great. Dr. Reddy, your thoughts, about the scope. And Dr. Trice brought out the important point about money driving this. So would there be a difference in the way like different countries operate with regards to like how the money is paid for different care?
Yeah, I think 2 areas I would comment upon for the data to be really become valuable for the entire health system. So apart from the theoretical uses of the data, but unless the entire ecosystem is geared for the use of this data, that means is the data interoperable in the country, across the country? Are there communication standards across the country? Are the data standards across the country? Is the data mandated to be transferred to a health exchange, health data exchange? I mean, this is what just I would like to share from what's happening in India in terms of the National Digital Health Mission. So as a part of that, if every citizen has a unique health ID, and there are national level registers of every provider, be it a clinician or be it a hospital or a diagnostic facility or a pharmacy. That means the data can be traced to every person, every provider. And if the data has to be collected as per laid down standards, I mean, some of the Western nations have already adopting these standards for the interoperability. Lastly, the legislative issue related to the privacy and the security of the data, because there is a growing concern for all this use to be really become practical. How do you address the issues of privacy and the security of the data? So this is one aspect of, so that means you have to prepare the ground in every country for this data to be really useful. The second area that I think the driver, I mean, what is going to drive this use of this data, especially the standards and all this advance of the digital health? As we know that the payer system has been driving the adoption of the data across the systems. And increasingly, the payer system is moving from fee-for-service to the pay-for-performance systems, especially the value-based care. In terms of what are actually the outcomes that you're providing for the money that you are paying. So when you look at the clinical outcomes data, because the outcomes cannot be measured as in a benchmark. I mean, it has to be measured against what is the expected outcome at admission to what is the observed outcome. Then only you can say whether the performance was as expected or below expectation or even exceeded expectation. For this to happen, and unless you have a robust AI system, I think humanly manual systems or individual level patient systems, we may be able to do it, but the variables are so many which can influence a clinical outcome. This is not humanly possible to really estimate what can be the clinical outcome. So this is where I think I see a huge amount of use of the data in terms of predicting an outcome and then trying your payment systems to the performance of those outcomes, what the patient report are outcomes. So these are some of the, what I say, system level issues in terms of leveraging the power of digital health. I think unless the system level issues are not addressed, whatever the potency of the digital technologies may not be fully leveraged and fully utilized. The third area that I think the future will see, I was part of the APAC panel, is on the precision medicine, the personalized healthcare,
Yes.
genomics are cropping up. So the genomic versus the clinical, the phenotypic correlation, unless you have a huge AI capability, you will not be able to stitch the genomic to phenotypic correlation in predicting individual level outcomes. So the precision medicine without a robust digital technology will not be a reality. So there is a convergence of the molecular technology and the digital technology, which will drive the precision medicine in the future. So these are, I think, the three areas I thought I will touch base upon in terms of the use of the data.
Okay. Dr. Reddy, I mean, you like put out a big variety of things. So does this data and the use of this data fit into your daily work? Or is it like, you know, your daily work with patients is one thing, and then it's very hard to get the inputs and, you know, what do you see? Are you getting proper data now? Or if not now, then what do you anticipate will happen in the near future?
No, I mean, it will be, I mean, it is being used and it will be used. It is only getting used to access to the data as earlier mentioned. What is going to be more important is the quality of the data. Having said that, we are going to use the data in real world. I mean, with every patient, we are going to use as a clinician, I would say. Similarly, as a lead who is running the heart failure program, I would like to look at my entire population data of the heart failure patients. I mean, how they are doing and what is their compliance rate with the evidence-based therapies. Why they are not compliant. I mean, why only 50% of the people are on actual data. So unless I have a robust data, that's how I use the data to improve my heart failure program, the performance of the program. So these, having said that, we also think there is a case to discuss on the flip side of the data. Especially when I'm looking at the wearable technologies, I mean, a lot of information the patients are getting. A ill-informed patient, actually, I'm seeing a significant rise in the anxiety levels of the patients because they don't understand the normal fluctuations of the heart rate, normal fluctuations in the blood pressure. Maybe an educated person may be able to understand that, but I deal with people, many of them may not be well informed. Even educated people, they are misinformed. I mean, they're informed but misinformed by the internet and other things. So we also have to be very careful because unless we address the flip side of technology, because every technology has like a knife. You can save lives, you can kill a patient, you can kill a person. The same way, I mean, there have been concerns that whether the data is going to be misused. For example, if an insurer is there and he can manipulate a pixel in the CT image of a person who is going to be insured and say that you are not eligible for this claim because you already had that evidence of disease. I mean, these are some of the concerns which are coming up in prestigious journals like Lancet and the JAMA and the NEJM. Just cautioning because sometimes we go hyper about certain utility and then suddenly you have to moderate when you notice certain flip side of that. So I'm a middle path man. So that's why I'm bringing that information, that also onto the panel discussion, that we have to be careful while there is a tremendous use of the data and the digital technology, but we have to be also careful that what is the unintended consequences of this data or the power of the digital technology. I mean, just like we rigorously test a drug or a vaccine or a device for its safety, the wearable devices, nobody is testing the safety of the wearable devices. What is its impact on the mental health? Actually, what is the impact on self-medication, a change in the medication and its unintended consequence of medical errors. So I'm just cautioning on the other side of the data and the technology, the evils of the data.
Dr. Trice, how about that aspect? Like, is the data useful to you in your daily work? And like Dr. Reddy said, like, do you see any bad situations?
Absolutely. I agree with Dr. Reddy from a clinical standpoint. So we're using, population health data. So I do a lot with narcolepsy patients in my current clinic. So we can look and say, how many patients are we seeing? What are the predictive numbers for this particular regional area? So what's the, rate of what we're missing? What are the standards of care in terms of medication? What are our response rates to certain medications? Are they matching up with what's, published information by the pharmaceutical companies? And then looking at other socioeconomic factors like why people aren't following up, getting predictive information based on someone's age, race, gender, socioeconomic status, zip code, to kind of get ahead of the game. So this is a very beneficial on the clinical side. I think there's two problems from personal side is it takes time. It takes time as this is a newer technology and we're trying to figure out how do we take this data clearly and accurately, because we get a lot of information, but how do we act upon it? And so, as Dr. Reddy alluded to, having people who are trained in this is crucial. And I think there's definitely a knowledge gap, not just among physicians, but particularly among the general population. We'll get a lot of people coming in with Fitbit data, as I mentioned earlier, things like this, and say, hey, I've got this information, what do I do? And to kind of talk about the negative effects is the side effects. There's a huge learning curve and time commitment that actually reduces the time I have with the patient explaining things that what I call unactionable data or possibly irregular or inappropriate data. So I think there, as he alluded to, there's some significant fears around privacy, around safety of your data, protecting the information, particularly when it comes to adding payers. When a patient comes in and is paying cash, there's not an issue. But whenever an insurance company is involved, whether that's a government sponsored or private industry, they have a desire to keep costs down. And so for some of them, using artificial intelligence to keep patients healthy at a low cost is great. But the fear is also being able to exclude rare and high cost diseases when people are borderline. So as a clinician, I think that's going to be the hardest part is, I think as we get older, and most of us, when we work in academic medical centers, we know about the standard of care, we know what's new, but there's always that one patient who's just a little bit outside the norm. And your clinical experience and your gut tells you that this is the right disease, even though the data doesn't support it. As my mentor would say, I don't have to do a biopsy to know who my mom is. You can say, I can look at that. I've seen it. I know the voice. I know the face. I know the hair. That's my mom. I don't need any data to tell me that. I've seen it with my eyes. And so as we particularly age physicians, and some of us who've been doing this for a while, we recognize clinical states that may not fit exactly into a category, particularly if a patient has difficulty with their medical terminology, the phrasing they use. So we see racial differences in terms of how people explain the same disorder. And so I think that the fear for the clinicians is that some of the patients that we see will fall out of the category and won't be approved for treatment. And we know that they've clinically benefited, although the data would suggest that maybe their borderline or the disease state doesn't fit. So I think there's a chance for misuse, and clearly it will happen to some degree. As Dr. Reddy, how do we do this on a grand scale to reduce that effect as quickly as possible, so that as we're aggregating this data to help improve it, we're not actually leaving large groups of people behind, because that's what the data shows us we're supposed to do. So being able to combine both the science and the art. And right now, the science is kind of winning in terms of artificial intelligence, but there is an art to how to actually use that data. And I think that's where hopefully the younger generation of scientists and physicians and physician extenders are really understanding that even though you have great data, there's something about the knowledge and using your hands and understand that is it's the experience factor. I think that's crucial.
Okay, so continuing on, we talked about some of the challenges already. And this aspect about the knowledgeability, currently what happens is there are people like me and my team who are software people who are manipulating and massaging the data and trying to extract insights from it. And of course, we work, for example, we worked with Dr. Reddy on on the heart disease data. But is this going to be sustainable, or is there going to be like a need for health experts to do more with the data as opposed to the software people? So Dr. Reddy, what would you say to that, please?
Yeah, I think, what happened with the pharmacy and the technology, what we call it as the division of bench to bedside, right? So the technology developers have been actually removed from the bedside. So in the process, what happened is almost 95, 98% of so-called innovation will never see the bedside because of this division of so-called scientist and the physician.
Yes.
The net result is that the wasted innovation of 98% wasted innovation cost is passed on to the 2% which sees the bedside. So that explains why the modern technology is so expensive. It should not be. So having seen that negative impact of this separation of bench and bedside, I think the digital technology should not make the same mistake. The digital health tech people should not be separated from the healthcare professionals. I think they have to work in tandem for it to be really meaningful and more accurate and does not lead to some unintended consequence. So yeah, I strongly believe that the technical people have to partner with healthcare people so that the real use comes out of that. Otherwise, we can see the same thing, the history repeating, that 98% of whatever you guys are working, all the startups are working, only 5% or 2% may see the actual use in the bedside. So that's where I think my own caution is that it is the right time that just like we started our partnership. I mean, you can appreciate the clinician's perspective. Similarly, of course, we can also appreciate what a technician's perspective. So this is essential because otherwise, many of the products, many of the ideas, they go waste.
Important point. Yes, Dr. Trice, you are, you are a physician. You are also the entrepreneur, and you're also like, doing your own work in data. So, is that the best recipe? Should all of us have some basic idea about medicine? If not medicine, then at least what, like Dr. Reddy said, the bedside.
Absolutely. I'm biased, so I'll give you a little background. I did 1 semester of engineering school, but I've been a tinkerer my whole life. And what I've learned by having a startup company built around a medical device, looking at artificial intelligence, is there is a tremendous language barrier between most technicians, lay people, and physicians. Then when you add in those who've studied business, you're really trying to get people who speak 4 different languages to have a similar goal. And I always say it's up to the well-educated to be more educated. And so for those who are at the top of their career, I think healthcare will really benefit when we monetize it in the sense, putting somebody in a cardiology office or putting somebody in a pulmonary office whose background covers both realms. Not saying it has to be professional background, but who has an interest in it, can really help translate why this particular device or software is useful. And then once the data comes, making sure that that is actionable from a clinical standpoint. The last thing you want is something else you're being forced to do that really has no clinical benefit, right? That's a waste of everyone's time and money and resources. But I think ultimately that would be the goal. I think, starting with medical education, for those who are interested in it, having courses that start with, introduction to healthcare. So, if you're in a medical device world, what I want to see is engineers and technicians and software developers and business people who have to take a 6 to 8 week course in basic medical care. Then if they're looking at a particular field, another refresher course or certification. I think it helps to understand, because what we do is not just data. The data is so crucial. It is crucial, but so much of it is human interaction. And I think the data, it has the potential to be very cold and calculating, and hence push people away from healthcare at the same time, or be manipulated. And so understanding, how that kind of user experience goes, not only with just a physician, but the product, whether it's a software or a service or a device, is also crucial. It's hard for physicians, we're busy. It's hard for business people, they're busy. It's hard for developers, they're busy. But I think having these collaborative teams, both at government levels, regional levels, university levels, but even within hospital systems, is an absolute must. One of the things I've been working on doing is getting a rapid improvement exercise to say, when I have a physician who wants more information, how do we sit between that physician's desires and the team designed to build it, and really come up with a product that not only that they can use, but that can be replicated. Because if it can't be replicated, to me, it's probably not really a good system. It may not even be providing accurate information.
Okay. So yeah, we have had like a good discussion. Let us see if there are, we talked about, some of the points. I had them in the form of the PPT, but we talked about like what the companies like ours, the so-called tech companies should do, and what the ecosystem should do. So we talked about that a little bit. Let's see if there are any attendee questions, please. Bhagyashree.
Yes, Prashant. We have one question. What is the patient role in consuming the insights? Would it be only for the healthcare professionals?
Yeah, Prashant, I think I would like to take, because in fact, I wanted to make a comment on this, because most of the time we discussed about the doctors, we discussed about the managers, public health professionals. But what matters most, I think, in the future is how the patient health record, the personal health record, which a patient has power over it and access to it and control over it. I think that is now just like the health system thinking has shifted from provider-centric to patient-centric. Similarly, the health data ownership and the right to provide access to that data ownership. And increasingly, I think as the technology is advancing with so many point-of-care diagnostic equipment, monitoring systems, wearable monitoring systems, or implantable monitoring systems, many of the diseases, there may be a stage where most of the patients can manage themselves to a large extent, aided by some of the data information that they have. For example, the diabetes. If you have a standardized care pathway and the algorithms, and you're able to monitor your own A1C at home using a mobile. So the technology is going in a direction where the patient and the family themselves are going to become the caregivers. So that's the power. I think the technology will actually shift the caring into the hands of the patient. What started a millennium back, where the patient used to visit the doctor's home, or doctor used to use the patient home. I think the healthcare will move more and more towards into the hands of the patients and their families and the caregivers. So that is going to be the power of the data. I think similarly, at least from the National Digital Health Mission in India, every patient is going to have now the authority to actually give the consent to share their data with multiple providers. So it will not be in the domain of a provider. I think that is the true democracy of taking back what actually rightfully belongs to the patient.
Wow, okay.
That's good. We have one more question, rather two more questions. Are smaller organizations working on insight? Are smaller organizations working on insights, or it is mainly the big ones like Google and the universities like that?
Trice, you want to?
Yeah, I can answer this. I think it's, believe it or not, both. So, I think some of the larger companies, particularly, India, the US, Norway, Holland, certain places in the world, they have companies that are, multinational corporations that are clearly looking at large volumes of population data and how to make money off of it clearly. But I think there are significant health centers, not even the larger ones. Some 3 to 5 hospital systems, because they're the ones really on the cusp where this is an economic problem. They don't have the beds, they don't have the space. They're seeing more and more people coming from more regional areas, and they've got to figure out how to accurately treat patients and keep them at home. So there's a big push on some of the more progressive ones. I think they're partnering with small companies in terms of really just gathering data at this point. Some of them using it in predictive analytical models as well. The most progressive ones have even instituted treatment programs around that data, not just using devices, but also subjective data, patient questionnaires, and really analyzing it. So I think there is a mix. You know, you'll hear about the large corporations doing it, of course, and the Googles, the Facebooks, some of the Department of Defense and Department of Ministries or Ministries of Health in countries. But really, it's the medium to smaller size hospital systems that I think are being the most aggressive. And I think that's where we're going to see the most impact.
Great, great. I think the next one is interesting one. Can too much reliance on data also pose a risk of medical errors?
See, I mean, I think medical errors, it's not about reliance on the data, as I think the Trice has alluded to. Medicine is both science and art. So if you become a pure technician or a technologist and forget about the humanism and the art of science, art of medicine, there is always a potential for making mistakes based on purely relying on the data. A good clinician, I mean, I use the analogy of shotgun approach to kill a person versus a sniper to kill a person. A smart clinician requires only 1 or 2 data sets to accurately diagnose a condition. A poor clinician requires 100 data points to diagnose the same condition. So it all depends upon how, in fact, one of the skill that is required to be trained to a medical student is the use of data, the most artistic use of data. So that's what I say. Like any technology for that matter, I mean, just like the medicines. In medical hospitals in the US, I mean, the deaths that happen due to the medical errors. So this is, I mean, we are again human beings, so I think the errors will continue to happen. Only thing that is where we have to take the precautions, how to minimize these errors. I mean, the potential errors and the harm that is like, so that's why I alluded to that. I mean, how rigorously we evaluate a drug, a device, a diagnostic test. The same rigor is required to evaluate a technology product, a digital technology product. I think that should be the message, that we cannot take it lightly, that it is safe. So yeah, these are a few of my comments. Yeah.
We have another question, but I think we are probably running out of time. So we will pass that along, and we will inform you of the response.
Yes.
This question.
We have a couple of more questions because we have a few questions on the LinkedIn too. So
okay, all right. So let's do that then. Let's take those separately. But I mean, you know, for me, this was just an absolutely wonderful discussion. Not only talking about data and information in healthcare, its good uses, its bad uses, but the combination of the technology with the art. I think that is important. And it is important that software product developers or data scientists, where I am coming from that biased or whatever group, that we learn more about what happens in the bedside, in the clinic, in the actual interactions. And that will help us do a better job with the data. And then the potential of the data will be, you know, the potential of the insights that come from that data will be much more and much better. Over to you, Bhagyashree.
Yes. Yeah, so this is quick about Harbinger. Harbinger Group is a global provider of software products and services. We have established in year 1990. So it's been more than 30 years we are into business. We have been serving customers from across the globe, right from North America, Europe, UK, Asia Pacific, and Middle East. Overall, as an organization, we are more than 800 plus individuals spread across the US and India. At a group level, we are three companies, Harbinger Systems, wherein we provide product engineering services focusing on health tech, HR tech, and edtech domains. Then we have Harbinger knowledge products, wherein we have products for the teaching and learning development professionals. To name a few, Raptivity, which is for rapid interactive builder tool, Quillians, which is an AI-enabled assessment generation tool. And then we have Harbinger Interactive Learning, which is the custom content development arm of Harbinger, focusing on e-learning development and content transformation. So in a nutshell, this is about Harbinger Group. And if you would like to have more information, feel free to drop us a line. With that, thank you, Prashant, and to our panelists for this wonderful discussion. I'm sure we are going to go back with some food for thoughts today. I would like to thank our viewers for joining this session through Zoom and LinkedIn. And thank you for being such an amazing audience. In the meanwhile, if you have more questions, feel free to drop us a line at hsinfo@harbingergroup.com. We have also given the email address in the chat box. Thank you once again. Take care and have a great one.